This is the first webinar, educational webinar launched by us for the year. We hope to continue doing this webinar so that we can allow most of our valuable physicians in our platform, that is the Association of Nigerian Physicians in the Americas, to come and teach you the community, and also teach other fellow physicians about topics that we should know about. So today we are launching this webinar with this very important topic, allergy and immunology. And we have amazing panelists lined up. We're so humble and grateful that they have agreed to come join us. We're going to be talking about so many things. Before we get started, we just wanted to review some housekeeping rules. Please turn off your phone, mute your phone. If you're going to answer a call, you can also turn off your video so that we don't get distracted, okay? And then after the housekeeping rules, we're going to do our quick welcome remark, and then we would also introduce the panelists, and we will wrap up. All right, so just quickly, statement of use. By attending this event, you grant permission to ANPA DMV to use your name, image, or voice in any of our electronic print. With that said, if you're an attendee and you want to not be identified, you can change your name just by clicking on, one of the tabs. You'll be able to rename yourself. Again, just a quick disclaimer. Today's activity by DMV ANPA is largely for educational purposes. And if you have any symptoms, we still recommend that you get evaluated by your physician. Lastly, views, language, and opinion expressed by the speakers or even attendees do not necessarily reflect that of ANPA. All right, so I'm going to introduce you to my co-moderator, and that is Dr. Onyinki. Dr. Onyinki is a board-certified orthopedic surgeon. He practices in the DMV area. DMV includes DC, Maryland, and Virginia. He's currently employed under Georgetown University, but he also practices in Nigeria, where he co-owns a surgical facility, and he will share that with you. And I guess I didn't introduce myself, but my name is Dr. Azuma. I'm a board-certified OB/GYN, and I am your co-moderator for today. You guys, please help me welcome Dr. Onyinki. Dr. Onyinki, it's your turn.
All right, thanks so much, Ebere. I also want to say thank you to our panelists for allowing us to intrude on their time, a weekday in the evening. We very much appreciate it. I'm very confident that the information that we will all get out of this will be enriching. It's particularly important at this time of the year with seasonal allergies being a concern for many of us, including my own kids. So I want to say thanks again to the panelists, and also thank you to those who've joined us today, and to everybody who's had a hand in putting this together. Our chapter has long recognized a potential ability to have dialogues like this. I think COVID-19 in particular exposed the need for all of us to be educated, who are facing a phenomena that many of us were unprepared for and knew very little about. So that need for education amongst physicians was highlighted, particularly more so than ever over the last year or more. And with that in mind, we started organizing Zoom sessions to allow us to discuss and dive into information as it was coming about. But we wanted to have a more structured, regular session, and that's what this is about. So we felt that the allergy season, and also the fact that the COVID discussion is still pertinent, would be one that would welcome the allergy and immunology expertise. So that's what we're doing here today. We hope to keep it confined to 1 hour. We'll try our best. It's a lot to talk about. The specialty, as we all know, is very broad. We'll talk about seasonal allergies, food allergies, medication allergies, and also COVID-19. So we'll try our best to keep it to 1 hour. So let me not take too much of that time. Let's go ahead and introduce our panelists. Let's say ladies first, in no order of preference or seniority, but ladies first. Dr. Akinyemi, Dr. Jana Akinyemi is one of our panelists today. She describes herself as a health enthusiast. She's an allergy and immunology specialist with a private practice presence in Silver Spring, as well as an academic practice in Johns Hopkins. As a physician, she's a co-founder of the Asthma and Allergy Associates here in Silver Spring. So we welcome her. We thank her for participating. Next.
1 second. Sorry about that. All right, go ahead.
I was going to mention that I've met Dr. Akinyemi when she was a medical student. I was a faculty at Howard, and she always had a great impression to those of us who, she never worked directly with me, but there was always a great impression on the way she carried herself and presented herself. Her partner, Dr. Nkiru Kosima, I hope I'm saying it right, is somebody I haven't met, but seems to have a great reputation as well. They're partners at the Alpha Allergy and Asthma Associates in Silver Spring. She also was a former academic, I hope I'm accurate, physician at Johns Hopkins, rising to the rank of assistant professor. Her training was in internal medicine, and the fellowship was in allergy and immunology. And she completed her residency at Hopkins in internal medicine, and a fellowship at the National Jewish Health and University in Colorado. She sees both adults and children, and we welcome her to this forum today. And last but not least, our next panelist is Dr. Raymond Nwadyuko, which means big brother. We're from the same area, Isukwato in Nigeria. I've known Dr. Nwadyuko for a long time. He's a giant in the community and expert in the field. Also a Howard trainee, although before my time. Don't let the gray hair fool you. He has a private practice in Maryland, and we'll give him a chance, and all the other panelists a chance to briefly talk about their individual practices. And part of the idea of this is to spotlight our experts and hope to increase the visibility of the good work that they do. So Dr. Nwadyuko, we also welcome you. So you can stop this share now. We'll go ahead and jump right into it. And once again, hope to get this done in an hour. The session is being recorded, so we would be able to share it beyond the participants that are here today. Just to be able to do this in an organized manner, we can start off with seasonal allergies, branch into food allergies, then medication allergies, and then finish with the COVID-19. So we'll start off with just a general discussion. I'm going to start off with Dr. Nwadyuko, who's the most senior of the panelists. And I think allergy and immunology, to some extent, is a little bit vague. Most of us go through medical school and sometimes even residency without an experience of an allergy and immunology rotation. So could you just broadly tell us today what the field is like and what the practice is like, just big picture wise?
Allergies generally, allergy and immunology is a subspecialty that I found very appealing when I was in residency. Prior to my residency, I spent a year and a half at Georgetown and Howard University Cancer Center doing immunology research. During that time, I came and I worked with the Department of Microbiology. So one of the things I did extensive study on is the immunogenetics of HLA antigen in terms of disease associations. So I guess that was for me, that was the anchor that sparked my interest in immunology. The residency, of course, I was totally focused in that area up until I finished at Howard. I opted for rotation within allergy, and then my experience was also exciting, and then I went forward to do applied for the fellowship, and then ended up at UCLA Harvard. Generally, the practice is it's an interesting area. One is that the spectrum of conditions are coming with, makes me feel extremely interesting. Before then, I will also allude to the fact that I spent 60% of my patients during fellowship was purely HIV patients at UCLA. And then that also become part of my arrangement with Howard when I came back to Howard, because I was running the HIV clinic at DCGR part-time, as well as my involvement with the Department of Medicine and Allergy and Immunology at Howard. So the immunology aspect is my major interest, even at fellowship. All the studies I participated in was also in immunology. Then in practice, generally, you tend to do less of immunology. Most of the things you do, centers around seasonal allergies, conjunctivitis, rhinitis, and as well as asthma. And then, of course, you get into food allergies. People also look up on you to evaluate patients with medication allergies. And along the line, too, I've been doing this for almost 20 years. So along the line, I have seen quite a few of immunology patients in terms of immunodeficiencies. I've also seen a whole varieties of other conditions like C1 esterase inhibitors, acquired angina, angina. So the spectrum of what you confronted with is wild, and then that's what makes the specialty very interesting.
Okay, awesome. I'll pull in Dr. Akinyemi now. What was your own pathway like? Was it also through internal medicine? And currently, how is the practice? Is there a huge pediatric presence, or is it both pediatrics and adults?
So similar to Dr. Waduka, I think in medical school, immunology was very interesting to me. And then I just started looking into specialties that I would be able to do more immunology, and then did some rotations in allergy. And that's really what I fell in love with. And that's what I ended up doing. And then I think in practice now, so I'm fast forwarding a little bit, but in practice right now, so we see adults and children. So we see from babies all the way to, senior citizens. And so that, like Dr. Waduko said, there's a wide range of what we see. So in terms of immunology, there's definitely the immunodeficiencies, and a lot of patients that actually come in with allergies or suspected allergies, chronic sinus infections and things like that. It's more of an immune issue, but a lot of them, it is allergic rhinitis. So of course we treat that, and then we treat adults and children with asthma, eczema, food allergies, drug allergies, and really a wide spectrum of different types of hypersensitivity reactions to different substances. But we also do things like hereditary angioedema, chronic hives, which we actually see a lot of chronic urticaria in our practice. And we also see things like idiopathic anaphylaxis, so patients who have reactions and we don't know the cause of that. So it's a very interesting specialty in the sense that there's a lot of investigating, because you have to figure out what the cause. I mean, I think a lot of medicine is like that, but I think in allergy, it's a lot of that investigating, and that's the interesting part. And the fact that we get to see adults and children, and that it's such a broad, you really don't know what can walk in your door any day. So I find that very exciting, and no day is the same day in our practice.
Okay, thank you. And we're pulling your partner now, Dr. Rokosima. I hope I'm saying your name right.
Thank you.
We can jump into seasonal allergies, and you can take the lead. It's that time of the year. A lot of our kids and even some of our adult patients are going through it now. Can you give us a quick nutshell on why this happens to some people, and we can maybe talk about how to manage it?
Right. So with seasonal allergies and what most people call seasonal allergies, most times they're referring to rhinitis symptoms, which are primarily nasal symptoms, but also that can extend to the sinuses. And also they have the eye symptoms, which is allergic conjunctivitis. And many times, so like my colleagues mentioned, the field of allergy and immunology is just kind of wide variety of things. On one end, you have people whose immune systems are deficient, and so they're immunodeficient. On the other end, you have those whose systems are hypersensitive. And that is the case with seasonal allergies, where the body is recognizing normal things in our environment as foreign, but it triggers a hypersensitivity reaction. And in those who truly have allergic rhinitis or allergic conjunctivitis, they make IgE antibodies to the environmental allergens or air allergens, such as the pollens and the animal dander. There's dust mites and even cockroach and mice that people can react to. And also modes, there are seasonal modes and there are perennial modes that release their spores throughout the year that can trigger reactions. But many times when people say seasonal allergies, for an allergist, we know that the changes in the season can trigger their symptoms, but it's not always what they think it is that's causing it. This time of the year, pollen is the classic trigger for seasonal allergies. And early in the spring, it starts with the tree pollens. And then about late May, the grass pollens start to come out, and those will also trigger symptoms. And as we get into the late spring, in the early summer, the tree pollens are pretty much fading away, and the grasses take over as the major triggers for those symptoms. And then later in the summer. And so when you think about like classic seasonal allergies, those are the kinds of triggers that would cause seasonal. When we evaluate those patients, we're generally performing allergy skin tests, and the skin test is supposed to detect whether or not the person makes IgE to an allergen. And if they do make IgE to the allergen, then it triggers histamine release in the skin. And when that histamine is released, then they have a positive skin test response to that allergen. And a lot of people might have seasonal symptoms and not truly have allergic rhinitis. And so it's really important to get the allergy testing done because there are other triggers that can mimic seasonal allergies. It's really the detection of IgE that determines whether or not the person truly has allergic rhinitis versus non-allergic rhinitis, which can be triggered by other factors in the environment, such as just the change in the temperature. Going from cold to warm during the spring is enough to trigger some rhinitis symptoms. And those people generally do not test positive for allergens, even though they come thinking that that's what they're allergic to. So it's really important to get a good history of the symptoms, the timing of the symptoms, and to go to the next step to test them to determine whether or not they make IgE to the allergens that are suspected to be the trigger.
Sorry. Thank you again for just a brief introduction to its seasonal allergy. The next question is for Dr. Nwanduku. Hi, Doc. My question, Dr. Akiyemi wrote a very good blog on allergies, and she talked about immunotherapy. She talked about the allergen shots, okay? So let's say a patient first, gets diagnosed after getting the allergen test and tries over-the-counter antihistamine, but is still symptomatic, would you then recommend the next step to get the allergen shots? Because after I read her article, Dr. Kinyemi, and I was like, oh yeah, you need the allergen shots. And maybe I skipped some steps. I don't know. It was just impressive. So is that the right thing to do? I mean, I'm an OBGYN, but I still manage, allergies. So I wanted to see what you have to say.
Yeah, that's a very good question. In selecting patients for allergy immunotherapy, there's a lot of considerations that we go to. First and foremost, you are ideally in my practice, if you go from one practice to another, you will see a whole lot of varieties, and these other colleagues will attest to it. In my, there's also college, practice parameter standard, practice standards. One of the foremost is that you have to have, there are three reasons why or conditions why we put people on allergy shots. One is, of course, is allergic rhinitis, allergic conjunctivitis, and allergic asthma. Okay, also can bring in the stinging insect allergy. That's another topic for that day. Once you determine that those three conditions I talked about, the rhinitis, the conjunctivitis, and asthma, the next step is to evaluate an individual patient and determine whether you are dealing with duration of these symptoms. If it's somebody that has only seasonal, we're talking about from early March to, let's say, May, June. To me, there's no rationale to put him on those all year round process or procedure. That's one, too, is that the duration of the symptoms is a consideration. Again, the other considerations are the cost, as well, relative cost in terms of the medicine you will use to the cost of the allergy. There's also the consideration of a patient who's not tolerating the medicine very well. There's also an issue of the, most times I don't start allergy immunotherapy until after 5 years old. Okay. The rationale for it is because some of those patients below 5 or so may not cooperate with the process. And again, even if they have developed symptoms, they're probably not going to be in a position to communicate those symptoms, which is side effect of their allergy immunotherapy. So those are significant considerations. Another consideration too is for older patients who may be on certain medicines for their cardiac or high blood pressure, like beta blockers. We don't generally put those ones on. And the rationale behind it is that if you're giving them beta blocker, in case there is a reaction to the immunotherapy, a tendency is to pick up epinephrine, which would, would not respond to a situation where all the receptors are blocked. So those are some of the considerations before we opt for allergy immunotherapy.
Okay, thank you. And Dr. Akinyemi, you wrote the blog. I also found it very fascinating and probably a good option for my own kids who suffer with multiple allergies. So I'm just curious, how effective is it? How well does it work? It almost sounds to be a holy grail potentially if you have people who are facing a possible lifelong challenge of environmental allergies. If there's a solution for this and other allergies in food and elsewhere, can you comment on how effective it is and what your experience has been?
Yeah, so I mean, I don't want to call it a holy grail, but I will say that it is, it's very effective. I mean, there's a range of effectiveness. It also depends on where the particular patient starts off. I mean, the patients who have severe allergies, I mean, they have a longer way to go to desensitization, which is basically the other name for what it is. So you're basically desensitizing the patient to their allergens. So Dr. Irkasima mentioned that, we're testing to very specific allergens. So I talked about on the blog how when you're taking medications, you're kind of just generally treating symptoms. Whereas when you're doing immunotherapy, you're actually targeting the specific allergen. So if it's cat or if it's oak tree, you know, very specific targeting. And so the therapy does work very well. And so it's not without side effects. The major side effect is really that you could have an allergic reaction to it. So we have safety protocols. Patients who come in, they get the shots and they have to wait 30 minutes after their shots. But it works very well. So in terms of effectiveness, which was your question, so, I mean, most patients, and I think we can say about 80% of patients are going to have improvement. The range of their improvement could be to no symptoms and then to much less than where it was before. So, I mean, it doesn't work 100% for everyone, but it has a very high effectiveness rate. And then it's not a cure. So we have to remember that most people will do shots for a period of about 3 to 5 years. That's the recommended time frame. And that is so that the benefits will last for many years. But it doesn't mean that if you do shots now that you won't, let's say as a child, that you might not have symptoms again when you're, 30 years from now, but it could be sooner. So we try not to like make guarantees, but we try to let patients know that it will likely be effective. The results should, if you're compliant with the schedule, should last a long time. There are patients though who have had shots as children and then they may need them again as adults. But I think the considerations of who it might be good for would be those with more severe symptoms, those who have symptoms year round. I mean, if you have multiple allergens and you're suffering all year round, you're taking medications all year round, those would be the ones that would be more likely to be compliant with a schedule of coming in for shots, for a period of 3 to 5 years. Also, the patients who are not responding to medications. So if the medications aren't working for you, then if they're working well, then the incentive to go on shots will be, not so high. But if they're not working well, it's a really great option. And it's something that I can just speak personally that I did allergy shots. So I have allergies and I had horrible cat allergies, and to the point that I would react if my patients would come in the room and they have cats at home. So I ended up doing allergy shots and it worked really well for me. But I mean, I can't speak for everyone, but I'll say that from the data, we have over 100 years of data of immunotherapy and it works very well. But you do have to be careful about the patient selection. But we do start, usually younger kids won't tolerate getting a shot that often. So typically 5 or 6 would be a good age to start. And then as we get, but we can treat all through adulthood. But even our little ones, the parents who decide to put their children on allergy shots, they have pretty severe allergies. So we're thinking about, these children are suffering and it makes a huge difference. And I've seen, and that's one of the really gratifying things about what we do is that it changes their daily lifestyle. I mean, it's a really, it's amazing how well it works for some patients.
Wow. Thank you so much, Dr. Akinyemi. That's a good place to stop. It does change their lives. So my question is for Dr. Ereko Sima. Okay. Dr. Ereko Sima, is it true that there's an association between diet, like your neonatal diet, and your allergies? Meaning, if we feed kids early with peanut butter, that means they will have less allergies to peanut butter. I mean, have you heard of that? Because I've heard of that. And lastly, for all of you, can people get the allergy shots at your practices? Okay, and this time let's keep it a little bit brief, like 2 minutes, just because of time and topic. Thank you.
With regard to feeding children early certain types of food allergens, there is some truth to it. There's been different data over the last several decades, but more recently, there's been solid data that came out of a study showing that early introduction of peanut into the diet actually helps to reduce the risk of developing peanut allergy later. And so that changed the guidelines actually just a couple of years ago, where we were now encouraging people to start introducing peanut early, of course, like about after 4 months, so like 4 to 6 months. Prior to that, the recommendation was wait and try to introduce some of the less allergenic foods into the diet. And peanut would be one of the later ones that you introduce during the first 12 months of life. But now it's recommended that for patients who are not high risk for developing allergies, that you can introduce it early. And even for some of those with some relative moderate risk, depending on their history and the family history, that you should introduce peanut early. Now, that data is speaking to food allergy. We can't really predict who's going to develop like allergic rhinitis or asthma based on diet, based on what they introduce early in life or not. That data is specifically for those who might be at risk for developing food allergy and how you can try to prevent the development of food allergy.
So that's an excellent segue opportunity to dive into food allergies now. So I'll pull Dr. Nwaduko back in and just maybe elaborate on why some people seem to be more vulnerable to food allergies than others, and what is it in the food, and what kinds of foods generally. So 3 questions in one.
Food allergy, just like every allergic illness, is one genetic predisposition. So genetic factor is one in terms of, and like she said, the predisposition also, risk factors introducing some of them early, and then the more importantly, the spectrum of what we see in quote unquote food allergy and allergy practice is wild. It comes from real food allergy, which is IgE mediated processes, to some what we call pollen food allergy syndrome, or the oral allergy syndrome. And then there's exercise-induced food allergy, and there's some other ones that's really associated with atopy. It's not quite considered a food allergy. Things like eosinophilic gastroenteritis. So most of the time in practice, what I have seen over the years are people come in here with what I consider as food intolerance rather than pure food allergy. What was the second question again?
Is it all kinds of foods? Are there some kinds of foods that are more likely to be triggers?
There are basically 3 or 8 classes of food. We have I'll go through them. One is the egg, cow milk is in that list. Shellfish, fish is also in that list. Wheat, tree nuts, peanut, as well as soy. Their distribution is kind of different depending on the age. Less than 3, you tend to see more of the tree nuts, peanuts, egg, cow milk, soy, wheat. And in adults, obviously you see fish, shellfish, tree nuts, and the peanuts. There's also a tendency for people to, if you look at the list, if you consider the list for the kids, 6 prominent major allergens, food allergens. As they grow older, they tend to grow out of it. There's been a lot of evidence that people, even in my practice over the years, I have seen a lot of patients grow out of their, particularly the cow, the milk, and the egg, as well as the soy. What was your final question?
And actually, I think you actually touched on it a little bit. There was a question from the chat, and we can use this opportunity to address that, which is the occurrence of food allergies. Is it equally present in resource-poor countries? With that in mind, I'll also ask our panelists to help us take a look at the chat so that if questions come up, we can use that opportunity to provide answers, because we're going to be continue to move along in the interest of time. But Dr. Nwaduko, you could answer that if the occurrences also occur. I guess we're talking about Nigeria and other resource-poor countries.
To be honest with you, there's no reason why it shouldn't be there. Our problem in Nigeria is underdiagnosis. So if you don't have the expertise, material as well as the personnel to diagnose, nobody will know what was wrong with the patient. I think there is, for few of them that have come over here, even the ones that live in Nigeria and visit my practice, they have seen quite a significant number of food allergies.
I'm sorry. Dr. Kiemi, what are like some symptoms a patient will present with, let's say, with allergies? For example, would we say lactose intolerance is the same thing as cow milk allergies, or what are the symptoms you see mostly?
The symptoms with food allergy, or you mean just food allergy? So with food allergy, so there is a difference between what you would see, although there's some symptoms that overlap. So typical food allergy type symptoms would be swelling, hives. You could have respiratory type symptoms, such as shortness of breath. You can have coughing, you can actually have fainting. So if someone has a severe allergic reaction, anaphylaxis, they can actually pass out. So it's typically more of like the itchy, swelling, that kind of thing, vasodilation related symptoms. Now with symptoms of food intolerances, or for example, lactose intolerance, it's more of gastrointestinal symptoms. You can definitely get with traditional, what we would call IgE mediated allergy, you can get some gastrointestinal symptoms like nausea, vomiting, diarrhea, abdominal cramping. So those are the kinds of symptoms that could potentially overlap because patients can definitely get abdominal pain and diarrhea with lactose intolerance. And sometimes that's the only symptom that someone may get. So you really have to get a really good history. Typically lactose intolerance would not, progress to anaphylaxis, a severe allergic reaction, and treatment would not involve antihistamines or epinephrine. But there is a little bit of symptoms that kind of are similar, but mainly in that gastrointestinal realm. But everything else is more of a traditional IgE-mediated allergy.
Keep moving along, Dr. Kosima, you brought up in your blog penicillin allergies. We're going to switch now to medication. So the two big ones in my practice, penicillin and sulfur drugs. And then there are people who have a lot of allergies to pain medications. So can you give us a quick overview on medicine allergies, how it happens, how real it is, intolerance versus allergy, and what to expect when patients have real allergies? Aspirin, I see, Nsaids, opiates, tramadol. In some cases, people have a genuine history of itching and rash. In some other cases, it's more of heartburn, which obviously most of us will not categorize as an allergy. But there are other cases where it's vague, and we just stop giving them medicines. And some people have an expansive list of medicines that they cannot take. So it can box us into an inability to prescribe appropriately.
For the approach really for us allergists, whenever we see someone who's got a reaction, whether it's a drug or like a food, especially with adult patients, the first thing that we always want to ask, and with children too, is this an IgE mediated reaction or is it not? And that's really like, those are the broad categories that we're looking at, because we know that if it is an IgE mediated reaction, then that patient is at risk for potentially having anaphylaxis to the drug. But if it's a non-IgE mediated reaction, then the risk of anaphylaxis or a reaction that might mimic anaphylaxis are much less when it's non-IgE mediated. Now, going back to some of what Dr. Akinyemi said in terms of the symptoms, we're looking for similar symptoms to what she described for food. So we're looking at certain systems. So the skin, are they having hives? Are they having angioedema? We're looking to see, are they having GI symptoms? Are they having respiratory symptoms? And if they have respiratory symptoms, are they having more upper respiratory symptoms where they feel like my nose is congested versus my chest is tight and I'm wheezing and I'm coughing and can't breathe? Are they having gastrointestinal symptoms, any cardiovascular involvement? So is the blood pressure dropping? Is the heart rate changing, bradycardic or tachycardic? And is the person losing consciousness? And the difficult and the challenging thing with drugs is some medications can actually trigger adverse reactions that look like allergic reaction, but it is non-IgE mediated, because when we test them and when we challenge them, we can tell whether or not it's IgE mediated. And and that's why I asked what medicines, what types of pain medicines were you referring to? So the opioid medications, for example, they cause direct histamine release in the body. And so that will lead to hives. It could, and for most opioids, that's exactly what it is. And when that happens, though, so depending on the severity of the reaction and patient comfort and also physician comfort, you kind of make a decision as to what the benefits and the risks are of this patient continuing with this medication. And you have to make a choice as to when an alternative is preferred. I would say whenever someone has a significant adverse reaction, it's usually best to just go to the alternative. Now, if we know, so if a patient tells me, for example, that they had a rash all over with morphine and there's no alternative for them, I know that morphine causes direct histamine release. I tell them you're likely going to have the same type of rash again if you get morphine, but if there's no alternative for you, what we're going to have to do is just pre-treat you with antihistamines so that we can reduce the severity of the hives that you had. But I'm usually pretty confident that they're not going, because of the nature of morphine itself and the nature of that type of reaction where it's causing direct histamine release, they're less likely to have anaphylaxis. But if a patient tells me that, let's take a different medicine, penicillin, I received penicillin, and within 1 hour, I developed a rash and I started swelling, my tongue swelled, and I had difficulty breathing. So the severity of the reaction and the type of drug that it is starts to give us an idea of whether or not this might be an IgE-mediated reaction, one of the ones that you don't want to proceed with. You really want to look for an alternative, at least until the patient has had formal allergy evaluation. And so that type of reaction to penicillin or another drug, maybe not penicillin, but when you have multiple organs being involved, so you've got the skin is involved, they have respiratory problems, or their airway is compromised because they're swelling in their throat. Those are the types of medicines that you definitely don't want to reintroduce to that patient without having them see an allergist first. So, but I would say in general, anytime there's a significant adverse reaction and the patient is saying, I have an allergy to this medicine, then I think they should see an allergist. We see a lot of patients who have multiple drug intolerances. A lot of times we're explaining to the patients that these are adverse effects to the medications and not likely going to cause like a life-threatening reaction, but there are some that will truly cause a life-threatening reaction. And that's really why they should see an allergist so that they can help tease that out. Now, certain medications like the Nsaids can cause non-IgE mediated severe reactions. So Nsaids have a mechanism by which they can trigger respiratory symptoms that's not caused by IgE, but the severity of the respiratory symptoms can be pretty high to the point where it becomes life-threatening and the patient needs intubation. And so if a patient does have any kind of lower respiratory symptoms when they take an NSAID, meaning like they're wheezing, their chest is getting tight, or they start to have significant swelling that involves their airway, then they should really avoid it. Now, those are non-IgE mediated reactions for some people, but they're severe enough where we don't want to reintroduce it. And if there's no alternative to the medicine, then there's drug desensitization, which an allergist definitely has to be involved in if a patient is going to be desensitized to the drug, because desensitization allows one to tolerate a drug only for the time, the duration that they need the drug. But as soon as they stop that drug, they're still allergic to it. And if you reintroduce it without desensitization, there's a risk of anaphylaxis.
Dr. Berry has a question, but before she goes, just a quick follow-up. How come some drugs seem to create a reaction when you give them very quickly and not when you give them slowly? And that includes opiates, but also some antibiotics.
And so a lot of that really has to do with really the mechanics of infusion and what the drugs do in terms of like direct release of histamine, in some cases, vasodilation, which a lot of drugs do. And so slowing down the rate of infusion of the drug will reduce the chances of that happening. And it's not like, it's similar to what happens when we desensitize someone to a drug, but not exactly, because with desensitization, what we do is we introduce a low dose of the drug and we gradually, over time, increase the dose. But in those that have to do more with like the mechanics of what the drug is doing with infusion, slowing the rate kind of slows how much the patient is getting over time, even though it's just a short period of time. And that alone is enough to try to reduce like the degree of vasodilation or the degree of histamine release or whatever else is mediating that response.
Thank you again for that. Just in the interest of time, I'm going to go to Dr. Waduku. Dr. Waduku, do you think like some people have these medicinal allergies because they have better immunity versus someone that doesn't have the allergy?
No, I wouldn't. Just going by your reasoning, I wouldn't say they have better immunity. I'll give you an example, which is what I studied a whole lot in California. HIV patients are notoriously, highly sensitive to bacteria. If you recall, during the top of that pandemic,
I wasn't born at the time.
I know. They needed Bactrim for PCP prophylaxis. You see quite a whole lot of them becoming highly sensitive to Bactrim, and it's one of those medications that have have gotten used to desensitizing patients at that time. So I think that kind of just supports the assertion of having high immunity being reasoning for we've been talking about IgE. Most of those tendency to have allergy to anything is purely genetic. It's really those factors, and that's why you see a whole lot of it aggregating family. That's certainly one of the factors. Two is the other. We've also seen some conditions associated with drug sensitivity, like lupus. Sometimes some patients will take certain medicine and they have lupus and get out of the sun and they become photosensitive reactions. So the tendency for you to have reactions is purely genetics, and then of course the molecule involved is also important too. I'm talking about the drug molecules.
Thank you. Dr. Nyiki.
Okay, so we'll transition now to COVID-19. Today's discussion, as you might recognize, has been more of a broad one than a deep one. I'm sure all of these topics probably deserves a deeper dive, but I guess our focus was really to expose our membership and the community to allergy and immunology as a specialty. So we don't quite have enough time to dig too deep into this, but it's very fascinating and interesting. And I apologize that we're moving on without finishing some of the conversation. But we want to finish with COVID-19. Immunology has a prominent role in infections, including this one. So Dr. Akinyemi, what are your thoughts? From what we know, do you foresee immunity been permanent, and why do you think so, from either exposure or the vaccine?
So from what we know, the antibodies, they're not long lasting. I mean, I think we have a lot of data on that so far. Most recently, the data from the Moderna vaccine. So we know that those about 6 months so far, the antibodies are lasting. And we're not saying that that's the longest they'll last, but that's what we have right now. And then in patients who have had the actual infection, we've seen the antibodies lasting out till 8 or 9 months in some, but as short as 3 months in others. So we don't really know, I guess is the answer to the question, but it doesn't appear to be that these will be long lasting, or at least not at levels that would be protective, so there are probably some, antibodies, but they're not. So this is preliminary, we don't know because it hasn't been around long enough for us to have that data, but definitely patients are losing their antibodies. We know that. We don't have because vaccination is relatively new, we don't have the data yet to say when the antibodies will be lost from vaccination, but from patients who've had COVID itself, what I've seen, the longest really has been the 8 to 9 months. So that gives us a clue that probably vaccination wouldn't be longer than, I mean, we'll see. I really can't say, but this is just what I think based on the way the immune system works and the data that we have. But we'll have to see really how this pans out. But I think we should all expect that there's a high likelihood of needing booster vaccinations.
Okay, so my follow-up question on that, and maybe I'll bring a different precedent just to spread it around. Dr. Nsaids, obviously antibodies is a part of it, but what about cellular immunity with T cells and B cells? Those don't seem to be mentioned when we talk about duration of antibody, duration of immunity. Is there a potential that there could be an opportunity for longer lasting immunity through that methodology than what we see with the antibody measurements?
I'm sorry. So, that's a really good question. And we still don't know enough really about it, but we kind of extrapolate from what we know from some of the other viruses, such as, for example, the flu virus. So there are some immune responses that are more dependent on like your T cells, but we do know that for a lot of similar viruses that B cell response is critical. And the T cells are there to help the B cell response. They help really to try to boost that antibody production. But after a while though, eventually it seems to wane. And then there's also this whole issue of the variants with mutations. It's hard to make long-lasting antibodies, that's what the cells that we call the memory B cells do, is that they help to create a memory of what you've been exposed to, the infection you've been exposed to, or a vaccine that has activated an appropriate response. And we don't know that we can make the right antibody as their mutations ongoing. And that's another critical issue there. But for what we know about similar viruses, the T cell response is not necessarily enough to give you that long lasting protection that you need, because the antibody response is really what's critical to preventing these types of infections.
Like they pointed out, the immune pathways, it's actually for us to understand in terms of how long these things will last and how free. One of the commonest questions people always ask me is that why come Johnson & Johnson is just one shot while the other ones are 2 doses, and then you also have, remember the yellow fever you get once, and then you have 10 years. If it's hepatitis A, you get one, 6 months later you get another one. Then within that 6 months to a year, you get a second dose for 12 years. Those are some new directions in terms of understanding the vaccine technology or an approach to improving what we have. You know, like they pointed out, you have all these immune pathways, the B pathways, the T pathways. Even within the T1, TH1, TH2, TH3. Of course, the T2 is only, TH2 is involved with the allergy pathways, but the most of the viral response are T cell dependent B cell response. Once the process involves, like he was saying, some initial clonal T cell, activation, and then eventually the transformation of the B cells into plasma cell and memory cells. So within each pathway, there's a different components of it. You have the memory cell component, the plasma cell component, the early response, some of the initial B cells that gotten activated, they will start spilling antibodies to protect the individual initially. And then of course you see the T cells. So our understanding of the duration and understanding and the quality and quantity of this component within the pathway is the key for us to determine how long they last and how often do you give them, or whether it's one or multiple doses or booster doses, and how long. So it is a very, very complex cellular process involved in that determination.
Wow, thank you so much, Dr. Waduku, for bringing up Johnson & Johnson vaccination. As someone with a public health background, what's this buzz about this cerebral venous sinus thrombosis, and how can we convince the population to go get the other vaccine with this problem?
That's a very good question. What I do, I've done it here in the practice, is I just have people compare, first of all, Johnson & Johnson, what we have now is, we have basically a rate of thrombosis with Johnson & Johnson at the neighborhood of 0.004%. Meanwhile, your cigarette is almost 0.2, and your birth control pill is about 0.1. HIV itself is about 16% thrombosis. So all of these are risk benefit. So it's really a risk benefit issue rather than, I to be honest with you, the idea of pausing, is essential, but at the end of the day, it's the risk favors continue the vaccine, as far as I'm concerned.
But how come the other producers don't have the same side effects? So is there something with it, the Johnson & Johnson vaccine itself?
Of course, Johnson & Johnson is a little different, platform than the Moderna and the Pfizer, which is a messenger RNA. So like I was just saying, the understanding fully what these vaccines do, is also synonymous with understanding the immune pathways they activate. So we know that HIV is purely an immune inflammatory process. It's an inflammatory process purely. It's not the viral attack, it's just the inflammation that kills. And part of that process involves the endothelial damages, and the endothelial damage oftentimes trigger off the cascades leading to thrombosis. So to see the vaccine, even if it's proven to be associated with it, will not be a surprising event with that understanding.
Okay. So we're almost done. I'll throw a final question to Dr. Akinyemi. And this has to do with a question that's coming up more frequently now. Some people get the vaccine and then they measure their antibodies. And in some cases, they don't have an antibody response. Is there any suggested response to that? How do you possibly explain that? Now, I want to throw in a caveat also, keep that in mind. I myself have had varicella vaccine multiple times because every time I take a new healthcare job, we do titers, and my varicella never shows. But I've been exposed to chickenpox even among my own patients and never get it. So it seems like there's some vague phenomena where people are able to get immunity somehow. Maybe I am, or just luck. But um, is the antibody failure or lack of response from a vaccine a concern? How do you explain that?
Well, that's a good question. I don't know that I can explain it, but I might ask my other panelists to help. But I mean, there are people who don't have antibody responses that can be measured for different reasons. So it doesn't necessarily mean that a patient is not, or a person is not immune, but I mean, there are patients who don't make antibodies or don't make antibodies to a level that can be measured. But usually we're seeing that in patients with immune deficiencies. And actually one of the ways that we diagnose immune deficiencies is how a patient might respond or their titers to certain vaccinations. So, but in your case, as you've said, so there's patients who have actual immunity, but their antibodies are not measurable. So that I really can't explain. And so I would like to pass that on to someone else who might be able to answer that question for you.
Sure. I think that the way that I approach it, and really what we do when we evaluate people for immunodeficiencies, which is really where we do a lot of these antibody evaluations, you have to look at the early response to either an infection or a vaccine, whatever response you're trying to evaluate, versus the long-term response. And because if someone makes, so early response means that typically what we do is if you get a vaccine and we want to assess your antibody response to it, we're checking antibody titers 3 to 6 weeks. For most people, it's around 4 to 6 weeks, that 1 month period after. And there are people who they make the response. So they have an appropriate response in that 1 month period, but if now a lot of people don't like keep checking antibodies for like several months down the line, but if you waited a few more months and you checked again, you find that somehow their antibodies are kind of waning faster than might be expected. And so it's important to know first, does the person actually mount an appropriate response early in the immune process after they've received the vaccine or if they were exposed to the infection. And then if they mount an appropriate response, then we're usually happy because that means that, okay, their immune system seems to be working well. And then the question, and these are the questions that are harder to answer, is why does the response fade away over time? For some people, they're just not making maybe enough memory B cells that give them, because it's really the memory B cells that give you the antibodies that are much longer lasting for several months, for years, depending on which bacteria or virus you're testing for. And that's really, I suspect that for a lot of people, if you check it early in the process, you do see an appropriate response, but later they might lose that response. And maybe those are people who just might need to be vaccinated more frequently than others, but it's just something that's not well studied.
So we're almost wrapping up. But I just wanted to just ask about that last portion of your response, which is antibody response from B cells. In general, there's lifelong immunity to measles, to chickenpox, and to some other viruses. Does it mean that if you did titers on people, you will see antibodies in those people even 30, 40, 50 years after exposure? Or do you somehow have to test the B cells to see that they are immune to it? And I'm just bringing that up to see how we compare to COVID long term.
So the antibody response is really how we would know, because even for measles, mumps, and rubella, that's what we're testing for, because that's really the easiest test that you can get is an antibody titer. It's much harder to test B cells and T cells. You have to, if you're going to test the actual cell, you have to do some kind of stimulation test, and stimulation tests have to be done in control settings. And it just becomes really, outside of like a clinical study setting, it becomes relatively impractical to do that for like a general population. And so that antibody response is really what is more measurable and what can be done in a stable condition.
Thank you. I'm going to be asking the last question, and after that, Dr. Aham will do a quick wrap up. So this question is for Dr. Kiyemi, and it was asked by one of our attendees, Ms. Rose Ekpati. She was talking about skin allergies and eczema and how to test for it. And, you know, my understanding was eczema was an autoimmune disorder, but I guess it's not, and it's an allergy. So can you touch on it quickly, like the diagnosis, the management, and how to test for it, I guess?
Yes, sure. So eczema is actually another name for it is atopic dermatitis. So it is in that realm of atopic disease where we consider food allergies, asthma, allergic rhinitis. So, I mean, certainly some people's eczema is not related to allergies, but we actually see a fair amount of eczema, especially in children, related to food allergies. That's one of the, sometimes it's the first presentation of allergic disease in humans, eczema. So we see a lot of eczema. And so although it is, I mean, it's still an immune condition, right? Because it's the immune system, and it's a way that the body is responding to, it's like sort of like a hypersensitivity reaction. And we actually treat atopic dermatitis or eczema by treating the underlying condition. You know, we use topical steroids. If we find an allergy, actually just avoiding that trigger, that food or that environmental allergen can be the cure. I mean, it's not a cure, but it's the solution. So the biggest part in children, when we look at atopic dermatitis, is actually trying to figure out what the trigger is. And then that's the first part of management. And then once we figure out what that is, avoidance, and if that is not effective, then we will use things that suppress the immune response, so topical steroids. And there's also some new biologics that are effective against eczema. So that's my quick answer.
Sorry, I came a little bit late, so you may have gone over it already. I'm a pediatric endocrinologist, and I occasionally do talks for inner city families, mostly like single mothers with young kids and aren't used to taking care of them. And I do a talk about like preventative things, and one of the topics that I go over is eczema and things that common things that they go through. And one common question that they have with when we have our kind of free flags, I call it hour with a pediatrician, where they can ask any question they never have time to ask their pediatrician. One question that comes up frequently is treating eczema. You know, I go over the frequency of washing and how washing a lot isn't really helpful. One question that comes up a lot is like cocoa butter and like Crisco, and what are like the best lotions to use. I usually tell them like Lubriderm and Cetaphil because they have cetyl alcohol in them. I tell them to look for that ingredient on the back of whatever product they're thinking about buying. What kind of lotions do you normally tell them to use, especially when they say, oh, somebody told me cocoa butter and is the best thing to use?
That was supposed to be a quick question.
What lotions do you tell your patients to use with eczema is basically the question.
So I would just start by saying that more than what they use, it's how they actually apply it that matters. So with eczema, a lot of people don't know this, but getting water into the skin is important, because what aggravates eczema is dry skin, and also a lot of scratching. So controlling the itching and getting moisture into the skin is very important. And so what I recommend is there's actually a process called the soak and seal eczema treatment plan. Soak as in S-O-A-K, soak in water, and seal that moisture after soaking with a good moisturizer or whatever has been recommended for the eczema if it needs a steroid for a period of time. And some of the good moisturizers that we would recommend include Eucerin cream, and in no particular order. It's Eucerin cream, Aquaphor ointment, Cetaphil, the cream, and some people will use CeraVe, and also Vani cream. Those are usually the 5 that I will recommend. One of the 5 that I will recommend. Some of these are expensive, and some families would tell me that, well, I don't want to pay for that. I want to use what I have. If they want to use something like cocoa butter, first of all, it should be a cream, not a lotion. Lotions have a lot of water content and they evaporate. Well, when you put it in the skin, it evaporates, and very shortly thereafter, it leaves the skin dry. So the key is you want to use a cream. And if they use something that has the consistency of an ointment, such as Vaseline, which some families would tell me, I tell them that they need to make sure that there's enough water content in the skin before they apply the Vaseline, because Vaseline is just oil, it's just petroleum jelly. And so if you don't have enough water content, and you're applying just oil on dry skin, it doesn't give enough moisturization. The water content has to be appropriate, but not excessive as you would get in a lotion. So I hope that helps.
Wow, thank you so much, Dr. Kusima. What about shea butter?
Sorry?
What about shea butter? Shea butter.
So shea butter, cocoa butter, as long as it's the cream formulation, I think that I have a number of patients who use those and it tends to work well. But what I caution people is if you're using a skin moisturizer that has too much fragrance, that can irritate the skin, because eczema skin is sensitive and you don't want to use moisturizers that have too much fragrance, because that fragrance is a chemical that can aggravate the eczema as well.
Okay, thanks a lot. That was very helpful.
I want to say thanks again to everybody for participating today. I personally found it to be a very good quality discussion. It's the first we've done with the new format that our chapter is undertaking. And the essential goal is to take advantage of the expertise that we recognize within our chapter and even beyond our chapter in ANPA as a whole. So I want to encourage everybody who's here, who is a potential member, to take a good look at the Association of Nigerian Physicians in America. It's an umbrella association for those of us who have some connection to Nigeria by heritage, by empathy, or otherwise. And we recognize a need to have some collective solidarity, which can benefit us in multiple ways, and then ultimately help us impact Nigeria, which many of us recognize is behind in some respects. And I think there's strength in numbers that we can harness collectively. So we do have this association, and we welcome everyone here, including the panelists. We also want to use the opportunity to give additional visibility to our panelists. There are many of us here who just don't know each other. I, for instance, did not know that like Dr. Kusima had a partnership with Dr. Akinyemi until we started looking into this forum. So with modern technology, I think we should have that ability to connect each other and allow our larger Nigerian community and even beyond to be able to find that expertise within our chapter. With that in mind, for the association to run properly, we do have a membership. There's a dues, it's an affordable amount, and it helps us organize activities like this for the membership and for the community as large. And as COVID comes to an end, there are activities that we intend to do for the larger community, including our children. So pay attention to that and participate as best as you can. We're going to continue to do activities like this following the general healthcare calendar. This month, we felt seasonal allergies and the current COVID-19 environment made this specialty one of particular relevance. But as the year rolls on, there are other areas that we can expand into. Next month, the focus is going to be on mental health. So I encourage you to pay attention to our pages and follow some of the public service announcements, blogs, and a likely discussion such as the one we had here tonight. Thanks for your time. 1 hour on a weekday was what we promised, and it ended up being a little bit longer than that. As we do more of this, hopefully we can fine tune our delivery and get it to be more compact and be able to complete it in 1 hour. We recognize that there's a lot to talk about and we did not cover everything. And we want to have the opportunity and the potential to continue to disseminate information through other methods through our websites. But we encourage you to see any of our doctors. Dr. Nwaduko treats my kids. Dr. Akinyemi Enoha and her husband Tolu. She's an excellent doctor, and obviously her partner has an excellent reputation. So I encourage you to seek them out for any allergy and immunology related complaints, and also to refer them to friends and family. Finally, I'll say that we're building a directory of Nigerian doctors in the area, and it will be a resource that anybody will be able to use to find specialists in different parts of the DMV, and also to be able to connect to them. We have a social media presence on Twitter, Instagram. Today's broadcast will be shared on YouTube, and we also have a Facebook page. So I also encourage everybody to follow us in that manner and get updated on information as it comes along. Once again, thank you so much for your time and participation, and I hope you agree with me that we had a excellent discussion today. I want to particularly thank the panelists for sacrificing their time and for the contribution they've made through the blogs. I'll end there and say thank you once again. Have a good night, everybody.